Hello, everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I've been working with CCF for 10 years. I'm a filmmaker and a writer, and we have been working together in that past decade to create video content like the video you're watching, so live video series, as well as produced videos like short documentaries and patient-centric videos, treatment-based videos, all kinds of videos. We have a huge database, a huge library, and all with the same mission in mind, and that is to educate people and spread awareness about neuroendocrine tumors and the NET community. If you are part of the NET community or part of the friends of the show, let us know where you're from. I see a few of you already are. Canada, always in the house. At sunny Atlanta, Ohio, Michigan. And if you're new to the show, I want to say welcome. And go ahead and introduce yourself to everybody. Let them know where you are in the world. I love to see how far the program reaches. And I also want to encourage you to interact with the community, because the community will take care of you. A big part of the benefit of the show and CCF in general is cultivating that community. The information we're going to provide from our expert, from our guest today and every week. But the community, I think, is also very, very valuable. People sharing their own experiences and stories. So introduce yourself, say hello, and we're going to move on with the show. Before we do, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Without their support, we couldn't do the show. And we always like to include this disclaimer from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience, that you all at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, that last line is the real takeaway there. We're going to give you some good advice, some answers to your questions, but by no means do we or our guests know your specific case. So take that advice, take those answers back to your home team that does know your specific case, and make the best plan and path forward for you. Because if we know anything about this disease, each case is unique, and therefore each plan and path forward is as well. Today, I'm very excited to welcome back to the show for a second time, Dr. Satya Nanu Das. How are you, Dr. Das? Good to see you.
Great to see you again.
Appreciate you being here. For the folks that might have missed you the last time, tell us a little bit about what you do and how you're involved in the neuroendocrine tumor community.
Yeah, absolutely. So I'm a gastrointestinal medical oncologist at Vanderbilt. I help lead our NET program here. I'm really involved with PRRT and drug development, and so clinical trials, as well as delivering new forms of therapy for our NET patients is really kind of a big passion of mine.
Got it. I see Bethany chiming in. Hey, Bethany from Illinois. What's not sure what the topic is today? Bethany, on this show, we don't really have a set topic. We have specialists and experts like Dr. Das just explained, his background, where I think you can get a certain amount of value depending on what perspective and what they come from and what expertise they have. But there really is no certain topic today, so all questions are welcome. Dr. Das has said nothing is out of bounds, so go ahead and start sending those questions in. We're going to set up the show. Just a little bit of more information about the show. If we can't get to your question, just know that you can follow up with CCF either here on the Facebook page, or you can visit their website at carcinoid.org. And if you know someone who should be here right now for this interactive one-on-one session, go ahead and tag them in the comments and let them know the show's going on. We want to get as many people here as possible. We're going to have the show posted on the videos tab on the Facebook page, and starting Monday, we'll put it on YouTube, so you can always watch the replay, and there's a lot of value in that. The real value is if you're struggling with something, being able to get across a question to an expert that you wouldn't necessarily normally have access to. So let's try to get as many people here as possible. And also, my second ask, if you see a question in the sidebar that you also have or you're interested in the answer to, just under the question, you see, you can like it, you can reply to it. If you hover over the like button, It gives you the option to like it or love it or any emoji that that Facebook gives you access to. They all work the same way to me, folks, and that is to effectively upvote that question. If I see 7 people have liked the same question, I know there's going to be a demand for it, so I'm going to make sure to get it across, because every week we get tons of questions. Inevitably, we don't get to them all. So that helps me do my job better, which is to serve you, of course. We have a couple announcements before we get started today. So we have a new program here at CCF. And Dr. Das is actually working with us on the beginning of that program. And you may have seen some of this because we've already gotten some information and some questions from you all. And so we wanted to share this new web-based program where you can ask questions that will be answered by neuroendocrine cancer expert physicians. And it is called Ask the Experts, but it is not to be confused with Luncheon with the Experts, which is this program, which is not going anywhere. Okay, so this is our luncheon based off of it being at noon Eastern time where we are based. So we all get together, we have our coffee, or this is really seltzer water, don't tell anybody, or our lunch or whatever we have, and we get together and we kind of share this moment. Ask the Experts. You can submit questions through CCF's Contact Us form, and the questions, as well as the physician's responses, will be posted on carcinoid.org on the website. So for more information, visit CCF's website. Again, that is carcinoid.org, and follow the link that we'll post in the comments here to learn more. So on the back end, we have Grace and the CCF team, and we will post that link, but you can essentially submit questions that will be asked by experts like Dr. Das, and then they will be posted back for you. So that's another program that we're asking. Sometimes people don't get all their questions answered here, or they can't make the show. So there is no time, like certain time you have to be available like you have to do here for the show. So hope that helps. Check it out. Go to the website when you can. Go ahead and start sending in your questions, and we're going to go ahead and start taking them. But before we get started, I have my own question for Dr. Das. Dr. Das, I know very recently you came out with an article, which I'm going to read the title to, but then I'm going to let you elaborate on. I'm really interested in, and I know it was just published a few days ago, maybe a week ago, called External Validation of a Clinical Score for Patients with Neuroendocrine Tumors Under Consideration for Peptide Receptor Radionuclide Therapy, that is PRRT. Tell me about that article. Tell me about the relevance and what's important, the important information that came out of that article as, pertinent to our patients here.
Thanks for asking about that, Rand. So this
is also, one second, Dr. Das, could you, your audio is coming in a little bit quiet. I don't know if you can move a little bit closer, just speak up a little bit more. I can hear you fine, but I have these headphones on. Sometimes people, if they're in a noisy environment, might not be able to.
How's now?
It's still a little quiet. Let the folks hear you in the back of the room.
Okay.
That's it.
That's better. Okay. So thanks for asking about that, Rain. So this is something that we've been actually working on for a long time. Really, as we know, there's been no categorization system for patients being considered for peptide receptor radionuclide therapy. Mm-hmm. So we wanted to develop a scoring system, first of all, just to classify, who should be considered for PRRT and who might be an optimal candidate for PRRT. Furthermore, we never had a tool to actually tell patients that, this is what your particular disease and tumor burden may lend itself to what kind of benefit from PRRT. We would always kind of give more general numbers. So this score was derived from kind of those two areas. And then it kind of morphed into something else as well. As we all know, sequencing is the great unknown still in neuroendocrine tumors, particularly with PRRT. As you guys all know, there are a number of ongoing studies. The NETR-2 study, which is looking at PRRT in the first line, COMPETE, which is looking at PRRT versus everolimus. There's a French study called Octreotide, which is looking at PRRT versus sunitinib. But these studies are still years away from reading out. And so we still don't know as a field where PRRT fit. So our score shed two insights. So first of all, what we found quite interestingly is that patients with lower scores in our analysis actually did markedly better from PRRT. Now, that may not be so surprising for folks, but actually the lower the score, it seemed that the greater the benefit from PRRT, suggesting that actually earlier incorporation of PRRT, when patients have less pretreatment and have lower tumor burdens, may actually benefit them more so. So that was one of the main takeaways. And the second biggest insight is that now I can take this score for a patient that I'm going to talk to about starting PRT and actually tell them for the first time that this is what I anticipate as far as benefit from PRT. And that may shape kind of how we think about future therapies down the road.
Got it. Thank you so much. Well, I know from every week here on the show, we get lots of questions about PRT. You already kind of went to where I was going to direct some of my questions about sequencing, et cetera. We talk about this every week, so I know that we're going to get a lot of questions. I already see some coming through. So folks, that's really exciting. I think it's really going to help, because I know ever since 2018, this has been a really great tool and resource for NET patients, especially here in the US once it became approved. But I know there's been a lot of questions that have come up too that you've already alluded to. So I think the more that we know about it and how to utilize this tool, the better we'll be. So this is exciting. I think this is exciting times. Folks, we have outstanding numbers already today. We must have a great guest. I don't know. If you joined us a little bit late, we are here with Dr. Satya, aka Nanu Das, and we're talking about all sorts of things, but a lot of PRRT so far. I see that we have people from Alaska, people from Australia in the house, which is always interesting to me when people are either should be just waking up or going to sleep and still tuning in live to the show. That makes us feel really good, because it shows me that there's a lot of value here. So welcome to everyone across the world. And just know that if you weren't able to make it, or someone that you know wasn't able to make it, that the show will be here as soon as we're done with the show. It will be evergreen and live right under the videos tab here on the Facebook page. So, Dr. Das, we already have some PRT questions in. Let's start taking some from the audience. And our numbers are looking great. We have already over 100 people in the room. So Laura says, I just had PRT yesterday. How much water should I be drinking to properly flush my kidneys afterwards?
Yeah, Laura, thanks for that question. I think the more the better. There's not sort of a finite answer per se. As you know, with the PRT, you are also getting fluids with the amino acids that help flush the kidneys and protect them. But I think continuing to stay hydrated allows that PRT to wash out of the system, not hang around, and lower blood counts. So I don't think there's a fixed answer, but I think what I always tell my patients is however much water you're drinking, maybe an extra glass or two for the next few days.
Yeah, I guess, I mean, you can't, it's kind of hard to go wrong with the more water, right?
Mm-hmm.
I mean, eventually I'm sure there's a line somewhere, but
Yeah.
but drinking water is typically good. Hopefully that helps. Thanks for your question. Okay. Next question from Bethany. Any comment on how SUV numbers relate to the size of a mass on a PET scan?
Bethany, that's a terrific question. So SUV, I think in the context that you're asking, is in our somatostatin receptor-based scans. Mm-hmm. So dotatate scans, typically gallium or copper. SUV actually really measures the concentration of receptor rather than size. So you can actually have tiny tumors that are incredibly hot via SUV values. So it actually doesn't correspond to size, which is usually why on a gallium or copper scan, we have a CT component or an MRI component, which actually gives us an idea of size. But there are a lot of interesting questions that are being explored as to whether SUV kind of brightness correlates with response to PRT. And we don't have all those answers yet, but I think one of the themes that emerges is that the brighter the tumors are with regards to SUV, the more expression of the target there is, and therefore a better opportunity for PRT to work.
Got it. Got a comment from Susanna, says, hi, and thanks for all these sessions. They are so helpful. Suzanne, thank you for being here. This is what we do it for. And I want to go back to the article. We'll try to put a link to that in the comments if it's not already there. It probably is already there as well. But I also want to say that some of the co-authors of the article who've been on our show are Dr. Aman Chauhan, Dr. Shika Jain, and Dr. Robert Ramirez. Just wanted to give them a little shout out too. They are friends of the show, and we appreciate them as well. Karen says, what drug can be used in PRRT? I have had reactions to Octreotide and lanreotide.
Yeah, that's a really good question, Karen. So, the way that PRT was FDA approved was in combination with the somatostatin analog. Now, that being said, we do have patients that have sort of intolerance to somatostatin analogues. And so you actually don't need to absolutely get the somatostatin analog. You can just get the lutetium dotatate alone for 4 treatments. Now, honestly speaking, we don't have that data yet, but there are a few of those trials that we mentioned earlier, like that COMPETE study. There's this trial called COMPOSE, are actually looking at PRRTs alone without the somatostatin analog. So you don't necessarily need to get the somatostatin analog, particularly if it's caused some difficulty in the past.
Got it. Thanks for your question. Hopefully that helped. Next question from Marnie and a few other people. What clinical considerations factor into a decision to surgically debulk a PNET?
Yeah, Marnie, thanks for your question. I think, so this is a great question. I think a lot of the data that exists for surgical debulking has been in small bowel neuroendocrine tumors and not as much in pancreatic neuroendocrine tumors. We think of pancreatic neuroendocrine tumors as being actually a little bit more sensitive to our systemic therapies. So a lot of times, for example, I will use things like capecitabine plus temozolomide in the setting of a bulkier pancreatic neuroendocrine tumor. It's a sort of debulk disease before thinking about subsequent steps. But actually very recently, we just took care of a patient who had a pancreatic neuroendocrine tumor with insulin production and had refractory episodes of hypoglycemia. And in fact, Dr. Idris, our surgeon here, debulked the disease significantly such that the hypoglycemia resolved. So I think in my mind, the decision to debulk a pancreatic NET surgically has to do more of whether the tumor is functional or non-functional. If the tumor is functional, that to me may point me in a direction of perhaps leaning towards surgical debulking. But if a tumor is non-functional, I might try to do so with some of the systemic therapies that we have available.
Got it. Thank you. Thank you. Moving along, a lot of questions coming in today. Suzanne says, I had a very high 5-HIAA and carcinoid syndrome, but PET dotatate was clear. Is it more likely that I have a tumor without that receptor or that I have a tiny undetected tumor?
And this is a challenge, and I'm assuming that perhaps you had a neuroendocrine tumor in the past and perhaps now you're being watched. Or, usually sometimes there can be cells that are so small that are producing 5-HIA because you clearly have evidence of biochemical excess, but there may not be enough cells yet to form a mass that can still be detected. And so this is really a challenge. And so, sometimes if that 5-HIA remains elevated, in very rare cases, sometimes we do use Octreotide or Lanreotide to help manage symptoms, particularly if there was a history of a neuroendocrine tumor, but we may not be able to see it now. And so my sort of recommendation would be to continuing to surveil with scans to make sure that something doesn't develop that we can actually act upon.
Got it. Thanks, Suzanne. And this goes to Suzanne and anyone else. If you have follow-up information for clarification or just additional information and you're still on the show, you can always chime back in later. Do me a favor. It helps me because I don't necessarily remember everyone's question. Allude to or refer back to the original question. If you are doing that, just say just anything to indicate the question that we had mentioned before. That helps me, but just feel free to always chime back in if you're still on the show. There is no maximum amount of questions or comments you can make. Next up from Julie, I have daily Octreotide shots and I have severe nausea with every shot. I've heard of this many times. What can I do about this? Anything that she can do, Dr. Das?
Yeah, so Julie, I'm assuming that these are the short-acting Octreotide shots that you're on. Sometimes what we try to do, and I'm not sure if your team has looked into this, but maybe modifying the dose of the long-acting Octreotide. Sometimes what we do is we go up on the dose to see if that can reduce the need for short-acting or frequency. So if you're on Lanreotide, for example, increasing the frequency of the shot. Because I have seen that at times, that sometimes the short-acting shots can actually produce more of those symptoms. Now, if you do have to stay on the short-acting shots, oftentimes I'll recommend a patient to take a nausea med, maybe 30 minutes prior. So Zofran or Compazine are kind of our go-tos, and sometimes I can mitigate that. But I definitely feel you. I know that's not unique, unfortunately.
Yeah. Another question that isn't necessarily unique. We've had this question before. We've talked already a little bit about PRRT and the questions that surround it. Pam says, what do you recommend after PRRT? My husband will have round number 8 in March. And this question has come up before. It's like, if needed, what comes after that, in your opinion?
Yeah, so this is so I'm assuming, Pam, that your husband has gotten then 2 rounds of PRRT, perhaps initially responded and then got another 4 treatments. So I think first of all, what we would do is hope that we see prolonged benefit, right? So right now we would observe your husband, right, watching him closely with scans and so forth. There are a number of different compounds that are being developed, right? So there's actually a trial that's going to be starting soon, and actually Dr. Chauhan and Dr. Singh are helping lead that study, called the NET Retreat trial, which is looking at actually a second round of PRRT in comparison to everolimus. But clearly, as in your husband's case, in our practice here, we also have treated patients with repeat rounds of PRRT. It depends a little bit, if the tumor were to grow after that, what the primary tumor site is. So for example, if it's a small bowel neuroendocrine tumor, if your husband has not gotten everolimus or Afinitor, that is certainly an option. We will hopefully in the next 3 to 6 months be getting another FDA approval for a drug called surufatinib, which is a tyrosine kinase inhibitor. So perhaps that could be an option. And if your husband has a pancreatic neuroendocrine tumor, he certainly has other options like sunitinib, everolimus, capecitabine plus temozolomide, and hopefully surufatinib as well.
Thank you. I appreciate that. Thanks for your question, Pam. And she actually had a follow-up question about clinical trials. So Dr. Das already addressed that. Thanks, Pam. Let us know if you have any other questions. I want to go back. Some people may have missed, you were talking about, we were talking about the article that you wrote. And Albert asked, what are the factors that you mentioned, the score, the lower score? What are the factors that determine that score?
Albert, thanks for asking. So comprised of 5 categories. And so the categories are tumor bulk. So we actually, through a number of different folks, our surgeons or radiologists, kind of developed what constitutes critical organ involvement. And so we defined scores for each of those categories. We looked at the primary tumor site of a patient and what other options beyond PRRT were available. We looked at prior treatments. So what previous treatments had a patient received? We looked at tumor symptoms. And finally, we looked at the presence of peritoneal carcinomatosis. So those 5 categories were considered, and it was patients were scored from 0 to 9. And in our data, it was the cut point was 4, was what we defined as greater than 4 as being a high score and less than or equal to 4 being a lower score.
And the lower score, to reiterate, indicated that the PRT had a better chance of treating them?
Correct. Or PRT had a more prolonged benefit.
Got it. Okay, thanks. Thanks, Albert. And folks, feel free to ask questions if you did miss something, but sometimes we won't be able to get to them, and we'll just say, we'll tell you kind of where it was in the program and urge you to rewatch if you need to. Next question that I think I have seen before. It's interesting, but a few other people have this. Melinda says, can neuroendocrine cancer and Parkinson's disease be related somehow? A few other people were interested in this.
So it's a great question, Melinda. To my knowledge, and perhaps the neurology folks have a better understanding than I do, I don't know if there's actually a direct overlap. Now, that being said, some patients with functional or carcinoid syndrome I have seen worsening things like baseline Parkinson's and so forth, but I don't know if the diseases themselves are directly related.
Got it. Speaking of Dr. Chauhan, he is in the audience, as he often is. So hello, Dr. Chauhan. He says hello from Lexington. Good to see your name, my friend. Always thereabouts in the neuroendocrine tumor community. Next question from John. John says, how does PRRT compare to Captam, oral meds, regarding toxicity, specifically impact on platelets?
Fantastic question, John. So, this is a big time question, right? And so really we think about this a little bit more in the context of pancreatic neuroendocrine tumors. or higher grade non-pancreatic neuroendocrine tumors in which we think that CAP-10 is a bit more activity. So both of the drugs can actually cause platelet counts to go lower. I think of CAP-10 actually causing more quick platelet drops because both the capecitabine and the temozolomide can cause platelet drops, whereas the PRT actually causes significant platelet drops in only less than kind of 5% of patients per se. And so how I sort of think about that is when I'm giving a patient CAP-10, I always think about finite dosing when I can. So I actually, in my personal practice, I usually don't do more than 6 cycles at a time of the combination because the therapy can work long after it's stopped. And I do worry about kind of cumulative toxicity, especially if I'm thinking about PRT from a later on perspective. Now, I will say there is a clinical trial that will be opening soon in pancreatic NETs that is actually looking at randomizing patients to CAP-10 versus PRT. And that will be a very interesting study of looking at perhaps which one first may create a longer benefit.
Got it. Had a question from Ed also about the criteria that made up the score. So Ed, I hope that you heard the previous answer that we gave for Albert. Moving along. Ronald says, after being evaluated by a hematologist, I have a 2.5 to 2.7 white blood cell count. Does this mean I need to stay away from PRRT?
No, Ronald, that's not the case. I think really it's still something to be wary of. But the great thing about when you're on PRRT is that your counts are checked monthly, and we actually really don't think about PRRT causing neutropenia or a drop in kind of the infection-fighting white cells to that degree. And so really with the white count greater than 2,000, in total, we'd be comfortable with you proceeding.
Got it. Okay, next question from Daniel Tracy. Okay. KI 25% WD 15 cycles of CAP-10, shrinkage from 10 to 1 centimeters. Have you ever seen a complete response to CAP-10? The tumor is located behind the pancreas in front of the IVC.
That's an incredible response. I have not seen a truly complete response, which is the disappearance of all lesions. I have seen some striking responses like that as well. But it has definitely been documented in the literature that particularly if you've had such a profound response, that the visible tumors could go away because they've been killed to that degree.
Got it. Thanks, Daniel Tracy. Back to our friend Marnie. My husband has had 4 lanreotide shots to date monthly, and each one has been administered differently. Some nurses administer it all at once over 3 to 4 seconds. Some administer it over 20 seconds. Some pinch the skin. Some don't. What is the correct way to administer this injection, and what concern should we have if the injection is administered differently? And I got a very similar question recently. Any thoughts on this, Dr. Das?
Yeah, Marnie, this is a great question. And honestly, when you look at lanreotide and octreotide, they are, very similar drugs, but actually lanreotide seems to be a little bit easier to deliver because it is a deep subcutaneous injection, meaning you actually don't have to hit the gluteal muscle for it to penetrate. Now, that being said, there are absolutely nuances of how it's administered. Typically, we think about it being given over a little bit of a longer period of time. So, 15 to 20 seconds. Usually folks do pinch the skin as far as kind of our nurses who give this a lot so as to make sure it's getting in that space. There's some fantastic resources about administering lanreotide on actually the Ipsen site. And I think sometimes what we've done is actually are constantly in the process of re-educating our staff about pointing to those resources. So maybe something good to bring up to the team about just, whether the staff has access to that. Because I agree, giving it in a consistent way is absolutely the key to making sure it's working.
Got it. And one more time, we had just another question about the scoring system. Could you repeat the final criteria of the
Sure.
score?
I think it was peritoneal carcinomatosis present. So basically just disease along the lining of the intestines.
Thank you, Ed. Ed, let me know if that's the one that you missed. Hopefully that was. But again, please go back and watch the show if you did miss anything like that. So, question from Cindy. Cindy says, okay, she actually had Dr. Parrott from Vanderbilt, who's no longer there, was my PNET surgeon, and I've been NED since then. Do you recommend that I see a specialist routinely or continue with oncology visits only? I do have an Octreotide scan yearly.
It's a great question. I think it's, as long as you're getting surveillance at this point, that's important. I think the fact that you have no disease is fantastic. And that sort of lends itself to the fact that I don't think you necessarily have to rush to see a specialist. One thing that might be important, though, is as you approach sort of the 10-year mark, it may be a good idea to see a neuroendocrine specialist again, just to sort of talk about, if there's any further surveillance that warranted, what type of scan might be good to kind of do an end of surveillance scan. But I think you're in good hands.
Got it. All right. Thanks for your question. Next question from Elaine. Any studies on long-term use of Sandostatin and side effects?
Yeah, Elaine, thanks for that question. So because, Octreotide has been used since actually the mid to late 80s, there's been a lot of follow-up sort of data on it. As far as I know, I'm sure I'm sure there might be still something that's ongoing. But it's now more real-world evidence that has been documented from thousands of patients that have been on Octreotide. I don't think there have been actually any new safety signals that have been discovered. Of course, the big one is gallstones over a long period of use. And that's why a lot of times we recommend our surgeons to take out the gallbladder if any intervention is being planned for a neuroendocrine tumor patient. But beyond that, I have not seen kind of any emerging long-term toxicities that weren't previously noted.
Got it. Thanks, Elaine. Mary says, does PRRT have a less or lesser effect on peritoneal disease?
Mary, that's also a very, very good question. I think it truly depends on the receptor uptake of each of those lesions. So in general, because blood flow to the peritoneum is just kind of ironic. Though the peritoneum has tons of blood flow, actually the blood flow is through multiple small vessels rather than kind of our bigger blood vessels. So actually our blood flow and by default, our therapies penetrate the peritoneum a little bit less. And so, I don't think this has been truly established that peritoneal disease responds a little bit less. So I have seen responses in the peritoneum as long as those lesions are bright. But I think in general, it is safe to say that patients with peritoneal disease, it's not quite as robust of a response sometimes as in the liver. And actually, for example, not quite in the peritoneum, but there are certain sites of disease that just don't shrink as well. Dr. Strasberg and his group have published on mesenteric disease. So big, bulky, calcified lymph nodes in the mesentery just don't shrink as well because there's so much scar and fibrosis that even though the PRRT may be killing those cells, that scar is still going to stay. And so we may not see as much shrinkage there.
Got it. Thanks, Elaine. And Dr. Dotz just mentioned Dr. Strasberg, who's been on the show before and will be back in a couple of weeks, actually. So we're excited to have him very soon as well. Nancy says, what options are there for regular MRI and CT with tracer scans in light of elevated 1.35 creatinine levels?
Yeah, so it's a great question. The nice thing about the tracer-based scans is that they actually, so for example, like a dotatate PET CT is actually a non-contrasted CT scan. So the creatinine function is actually less relevant for us in that instance. And the same with MRI. Usually the MRI, even if there is contrast, it does not impair the kidneys in that degree. So it is safe to get a tracer scan with that degree of slightly elevated creatinine.
Melissa says, have you heard of any NET patients having heart issues after having COVID? I am currently recovering from COVID and having some palpitations.
Yeah, so that's a great question. I personally have not in my patients, but it is certainly not unheard of. And the reason is for folks with syndrome, any stressor, physiologic stressor, critical illness can actually trigger hormonal release and sometimes worsen carcinoid syndrome equivalents, one of which is palpitations. So it is not unheard of, I think, to get that, but I have not personally seen it in my patient population.
Got it. Sorry to hear that, Melissa, but I hope you're feeling a little bit better. Heather says, my husband is on cisplatin, hope I'm pronouncing that correctly, and Xeloda for tumors on his liver. The biopsy shows no markers for immunotherapy, and his liver tumors are not shrinking. So what are your thoughts on additional future therapies that they might explore?
Yeah, so Heather, this is a little bit of a tricky question because this depends on the grade and differentiation of your husband's tumor. So if this is truly which I think it may be from the choice and use of cisplatin, a poorly differentiated neuroendocrine carcinoma, then, it may be worth it to explore, again, perhaps other chemotherapies, but as long as your husband's disease is not changing, especially if it is a poorly differentiated neuroendocrine carcinoma, that alone is a victory because those cancers can be very aggressive. Now, if it is a well-differentiated higher grade tumor, there are certain alternatives that we would think about for chemotherapy. But I think the big thing to think about is that as long as he is feeling good, even if the cancers don't necessarily change or shrink in size, that's not always a necessary prerequisite for continuing therapy.
Got it. Thank you, Heather. Back to Mary. Mary says, I have my 4th PRT therapy next month. When would be the best time to do a CT to ascertain effectiveness?
Mary, this is also a phenomenal question, and something that we are still, if you, I think, ask 10 or 15 different NET experts, they may give you 10 or 15 different answers. So I'll answer in the way sort of that we do it. Usually for our patients that are undergoing PRT, particularly those with grade 1 and grade 2 tumors, we don't scan in the middle of PRT. So we wait till all 4 treatments are done. And then I usually get a CT scan or an MRI 1 month after the completion of the treatment to ensure disease stability. And then 3 months thereafter, may consider a dotatate scan just to kind of compare apples to apples before resuming a patient on their kind of usual surveillance. And what I mean by that is, so for a patient with a grade 1 NET, I usually do every 6-month scans. For patients with grade 2 neuroendocrine tumors that have perhaps a little higher Ki-67, I do every 3 months. But in general, I get a scan a month after the completion of PRT with CT or MRI.
Got it. From Azad, how do we know the right dosage of lanreotide? Is there a blood test for it? Something like that?
Yeah, Azad, that's a great question. So as with Octreotide, there is a single FDA-approved dose for it. So with lanreotide, it is 120 milligrams monthly. Now, we're not at that point yet. Perhaps at some point we will be, that we can individualize the doses. But we do have some evidence that in patients that, for example, have stable disease on lanreotide, but maybe still having worsening carcinoid syndrome symptoms, that we can actually increase the frequency of lanreotide. And in fact, actually, from our European colleagues, Dr. Pavel, in 2020, there was actually a study looking at increasing the frequency of lanreotide for tumor control. So for patients that had at least 6 months of disease stability on lanreotide, but had eventually grown through it, she and her group looked at every 2-week dosing of lanreotide, and it seemed to actually stabilize disease in a subgroup of folks. So the short answer is that we start with the 120 dose, but we can modulate the frequency of it. We don't typically change the dose of the lanreotide.
Got it. Thanks, Azad. Hope you're doing well. Next question from Richard. How should we think about risk of SS receptors declining over time, i.e. declining Krenning score, reduced uptake, and risk of losing access to PRRT? And what would be the theory on reasons for its decline? Other therapies such as Afinitor, Captem, etc.
Richard, that's also a really interesting question. In our experience and some of the stuff that's been published, we haven't seen actually prior treatments per se influence somatostatin receptor changes. But what can happen is that sometimes there are, as we all know with neuroendocrine tumors, these are very heterogeneous tumors. So even, for example, when we biopsy one spot and we say, you have a grade 2 tumor, there may be elements in there that are grade 3 or higher grade. So what I have seen is sometimes as higher grade elements emerge, somatostatin receptor can be lost. And so if we are observing somatostatin receptor loss, so for example, the way we think about that is, let's say after 2 years on octreotide or lanreotide, your disease progresses, that's a really good time to get a somatostatin receptor scan, because we don't want to just see that there's new disease, but exactly to the point that you raised, we want to see and make sure that the receptor pattern hasn't changed. Because if it has, that may motivate me to get another biopsy to figure out, is there a higher grade element that's lurking? And do I need to change my treatment approach rather than thinking about something like, for example, PRT, which I would think about if the receptor pattern hadn't changed at all.
Got it. Thanks, Richard. Appreciate your question. Next question from Cade. Cade, let me know if I'm not pronouncing that correctly. I want to make sure that I do. It looks like might be the first time I've seen you here in the audience. The question is, can traditional chemo be used simultaneously with PRT if a patient has a secondary cancer to treat as well?
So, Kate, thanks for your question. So I guess what you're asking is that, so let's say there's a separate cancer in addition to the NET, chemotherapy being utilized for that separate cancer, and the question is about PRT for the NET.
Correct.
So, Kate, it can be used, but it's a little bit of a fine dance, right? Is that certain chemotherapies, particularly depends on the other cancer, can be quite myelosuppressive in terms of lowering counts, lowering platelets. And so it has to be really well coordinated as to what therapies can be given with PRT. So, for example, I have had patients with melanoma and a NET that are being treated with immunotherapy and PRT simultaneously. And we've seen that to be fine, but we don't think that immunotherapy has the same myelosuppressive effects as chemotherapy. So I guess the short answer for my long-winded response is that I think it really depends on what that other cancer type is and what the other chemotherapy is. So that would be an excellent time to get input from a NET specialist to see, can the PRT be given concurrently, or should we wait till we can kind of get that other cancer in check before we treat the NET with PRT?
Got it. Folks, we got about 15 minutes left. We are moving right along today. The numbers have been consistently great for this show. So we appreciate you being here, but we have about 15 minutes left if you want to get in questions. We are going to keep moving forward with them. From Janace, how long after a lanreotide injection can PRT be scheduled?
Yeah, so Janace, this is also a very good question. And so I will tell you I think there are two answers here. The answer for how PRT was originally approved. So how PRT was originally approved is that we typically think of a 28-day period between your last long-acting somatostatin analog shot and the start of PRT. However, we realize that is arbitrary. In some of our patients that have had to get PRT sooner than that, it actually does not impair the effectiveness of PRT. Quite interestingly, actually giving a long-acting somatostatin analog, and we've had a few patients that have had this done, actually increases the tumor uptake of somatostatin receptor. And so I think the big thing is that when we can, 28 days should try to be utilized. But if there's a need to do that earlier, you don't have to worry that the PRT is going to be less effective if your long-acting somatostatin analog was given at a shorter interval.
Got it. Thanks so much for that question, Janace. Hope you're doing well. From Doug, I'm starting to take everolimus due to liver tumors discovered after being on lanreotide for 24 months. PNET Whipple had a Whipple performed 15 months ago. Should lanreotide be stopped at this point?
Yeah, so great question. What I'm assuming is that as most pancreatic neuroendocrine tumors are, that it's a non-functional neuroendocrine tumor. So in the setting of a tumor that's not producing functional symptoms, I think the lanreotide absolutely can be stopped and the Afinitor alone can be continued. The settings in which we continue both are when a patient, for example, has refractory carcinoid syndrome and their tumor is also changing. In that instance, we may keep the lanreotide or octreotide going. But I think in your case, fine to just continue with the everolimus alone.
Got it. We have a follow-up question from Julie, who we had a question earlier about the short-acting shot and nausea created from it. She said, in regards to my earlier question about nausea with my daily 100 MC shot, I understood your answer to include saying that these daily shots seem to be more provocative than long-acting. But my doctor is worried that since my nausea is so extreme that it would be much worse with long-acting. And he's not a specialist, because she lives in a rural part of the country. So that's what she was looking for your thoughts there.
I think it's, and this is a little bit of a tough question, right? Because everyone's body is a bit different. In my experience, we have seen that because the long acting tends to produce more of a steady state rather than kind of ebbs and flows, that the side effects tend to be a little bit more stable. So I actually would favor trialing the long acting, knowing that you can always use the anti-nausea meds that are there. But my feeling would be to try to move away from the short acting shots to utilize the long acting. One, because I think that's easier, and second, because I think your symptoms would be better controlled.
Got it. Hey, hopefully that helps and gives a little bit of clarification there, Julie. From Sherry or Cherry, I have very high levels of histamine, 2 different lab draws, and the whole body is itching and is affecting my quality of life. Do you see this very often or have any advice? And that's all the information we have. I'm not sure if you need any more to field that question, Dr. Das.
Yeah, I was going to ask Sherry that, is this in the context of having a known NET or not necessarily? Because there are NETs that can produce histamine. Lung neuroendocrine tumors are actually most commonly associated with that. But if it is not in the context of an NET, it may be best to actually, and certainly I think it's warranted to get scans to make sure there's not anything else going on. But I think it's worth it to see an allergist because you can have different processes like mast cells and things like that are kind of beyond our expertise that can cause excess histamine.
Got it. Hopefully that helped. And if you have, like I said, if you have a follow-up question or more clarification you want to add, we have a little bit more than 10 minutes. So you can try to get that in. And again, I'll reiterate, folks, if we don't get to your question, you can always follow up with CCF either here on the Facebook page. You can send them a private message or visit their website, carcinoid.org. Edgar says, will octreotide therapy become less effective over years of use?
A really good question, Edgar. I think, so if you look at all the data, it seems that over time, patients' tumors can slowly evade the kind of growth suppressing effect of octreotide. So in a sense, yes, over time, octreotide can become less effective, but it has to do more with the actual physiology of the tumor. So it's only if the tumor is truly developing resistance that we can see that. There are patients that are on octreotide for decades and still remain on it. So in general, yes, the tumors over time can tend to evade the inhibitory effects of octreotide, but it doesn't always have to be the case.
Got it. Thanks for your question, Edgar. Okay, a few people have this question, but it's coming from Paula. My nurse stated that she's having a hard time finding a spot to inject my lanreotide due to lumps. Are there any other sites that can be used?
Well, that's unfortunately a tough situation that we do see in folks over years. We think about these subcutaneous injections being given kind of in places that have some fat that can, and it can be administered. Usually, I have seen it being administered in other places and kind of the anterior abdomen and things like that. But again, that's not ideal. Really, the key is hopefully maybe alternating sides, or for example, if one side has less lumps, to try to use that side until the other side of the hip can recover. I will say this leads into something that's hopefully coming down the pipeline. There are, some studies looking at oral somatostatin analogues. Now, these are just being explored in patients with NETs. But the hope is that if we can at some point get an oral equivalent, that maybe, we can avoid the shots and kind of the things that happen after the shots.
Got it. All right, we're going to keep moving forward. Karen says, what drugs are used for immunotherapy for this type of cancer, for neuroendocrine cancer?
Yeah, so Karen, this is still an area of active exploration, and it really depends on the differentiation. So the data that we have for immunotherapy, and it's still, to be very honest, quite mixed, is more in the high-grade neuroendocrine carcinoma space or the well-differentiated grade 3 neuroendocrine tumor space. And it's not with single-agent immunotherapy. There is some data with combination immunotherapy, nivolumab and ipilimumab. But there are a number of studies that are ongoing. There's an NCI study that hasn't read out yet, looking at nivolumab, ipilimumab, and an anti-blood vessel drug called cabozantinib in the second-line setting for poorly differentiated neuroendocrine carcinomas. But as of now, we think that immunotherapy tends to have more of a role in combination in higher-grade neuroendocrine carcinomas. But in lower-grade NETs, there are a number of studies exploring anti-blood vessel drugs with immunotherapy. So some of these trials include that previous drug that we talked about, surifatinib, in combination with a kind of a newer immune therapy called tislelizumab. There are some ideas of lenvatinib, which is another anti-blood vessel drug, in combination with pembrolizumab that are being explored. So I guess the short answer is, on a trial basis in the low-grade NETs, we're exploring anti-blood vessel drugs and single-agent immunotherapy. In the high-grade neuroendocrine carcinoma setting, it's more combination immunotherapy at this time. And so that's sort of where we're thinking about these things, but they're still all being tested in trials.
Got it. Denise says, what's the difference between octreotide and lanreotide?
Great question. We think about them as just incredibly similar in terms of both of these drugs bind to the somatostatin receptor 2 most avidly and essentially turn off the signaling through a neuroendocrine tumor cell. There are some structural differences. They were made by two separate companies, Novartis versus Ipsen. And so there are some structural differences, but the mechanism of action is identical.
Thanks, Denise. Hopefully that helps. Anne says, what are the indicators for the second round of PRT, and how long after the first round should the second one ideally be?
Yeah, so Anne, also a really good question. So, that soon to be started trial will help us guide this, but in clinical practice, what myself and other experts typically do is we want to make sure that from the end of PRT, a patient derived at least 12 months of benefit, meaning absence of tumor growth for 12 months from the end of PRT for me to consider that again. Okay. In most of my patients, we actually who've gotten it again, they got much longer benefit the first time as well. But we want to make sure that it worked the first time before we try it again in patients.
Got it. Kate says, I've completed 4 rounds of PRT and have an insulinoma that hasn't been resolved as expected. Everolimus is being prescribed for its insulin-lowering side effect. Does that sound reasonable?
Yes, okay. It's a great great question and a tough situation, right? And we talked about functional pancreatic neuroendocrine tumors being rare, and insulinoma sometimes being the most difficult to respond even to systemic therapies. I like everolimus in this setting because actually one of the side effects of everolimus can increase blood sugar a little bit, so it can balance the hypoglycemia. One of the things that I might think about in this setting is that if it persists despite the tumors looking stable on scans, would surgical debulking be an option here? Because can we get you free of hypoglycemic symptoms? So this would be an instance where I think getting some input from a surgical team would be valuable.
From Dwayne, can a non-functional PNET become functional?
So Dwayne, I've learned in my short experience to never say never, but in general, functional tumors are what they say they are, and that usually functional tumors stay that way, and usually non-functional tumors do not kind of evolve into becoming functional.
Okay, thanks, Dwayne. From AG, what is your criteria for proclaiming a patient NED, no evidence of disease?
It's a really tough and fantastic question, AG. And I think a lot of that has to do with we can now look at patient scans in a much more powerful and deeper manner with somatostatin receptor-based scans. So if I were to ever make that declaration, it would be in the context of a patient that had a dotatate scan before, was resected or had a complete response, and then had a subsequent dotatate scan that showed no disease. I think, there are many folks sometimes that, dotatate didn't exist till the last 3 to 4 years. So folks were declared to be no evidence of disease. And perhaps now on a follow-up dotatate scan, which we don't use routinely for surveillance, but sometimes we'll get at kind of the end of the follow-up period, a new tumor might be noted, but it may not truly be new and may have been there sort of all along. So I think the only instances which I would be comfortable to declare that would be if I had a pre and post dotatate scan to show no uptake, if the tumor was initially avid.
Got it. Folks, we have time for maybe 1 or 2 more questions, depending on the length. Our next one comes from Olga. It says, hello, one test has showed a KI of 20 to 30, and the other one 90%. What should we do? Is the treatment different for KI of 90%?
Yeah, Olga, this is a really good question. I would, if possible, make sure to have that pathology reviewed by a NET center, just to make sure. In my eyes, it does. We usually default to using the higher Ki-67 as kind of the driving force. And if it is a well-differentiated neuroendocrine tumor, 90% Ki is incredibly high. And that would change our management in terms of some of the treatments that we would offer. So I would just make sure that that 90% is real. But in any event, this does sound like a grade 3 neuroendocrine tumor, but the key thing is to make sure that it's not a poorly differentiated neuroendocrine carcinoma, because that would change the way we approach the situation.
Got it. Dr. Das, we've had a really great group today, a lot of great questions. And it seems to me that we've had a few people that are kind of their first time here. And we talked about that before we started recording, that we have a lot of people that are here every week, very well educated. And then, of course, there are new people to this journey every day. Before my question, I want to say, Julie says, thank you. My doctor consistently tells me that he appreciates the information I gleaned from these incredible talks, as do I. Julie, thanks for saying that. That is what our job is. That's what we're here for. And Ed says, great presentation today and information and great questions. Thank you. So Dr. Das, my question is, and this will be our final question, for someone who maybe in the audience that is new to this disease, new to the show and new to the disease, where do you start in terms of your advice? What's that first step? If someone just gets a diagnosis, how do you guide them?
It's a really good question, Rain, because this is a journey and it truly is an odyssey. And I think in this odyssey, you need to have the right folks steering the ship. And I think the big thing is, of course, we're diagnosed. We have no control over when someone and where someone is diagnosed. But I think the key thing is meeting a trusted local oncologist and getting them to, they may be a neuroendocrine expert themselves, but if not, getting them to send you to a neuroendocrine expert, I think is really important. I think the perspective that you get, even whether your treatment is given locally or not, can really be shifted by that second opinion. And even amongst our patients that see neuroendocrine experts, we often have other folks go to other neuroendocrine experts, and we welcome that. You mentioned Dr. Chauhan being on the call. Dr. Ramirez is always on many of these calls.
Yeah.
The neuroendocrine community and sort of our paper speaks to this. We have a unique group of individuals. We are lucky in that we have such a collaborative group of physicians that are willing to work together, and projects like this paper are an example of that. And We have other projects in the pipeline as well. It's because we're willing to share both our experiences, our trials, and these things. So I think the big thing is that if you can, go see a neuroendocrine expert and get that perspective. And because we are always willing to work with your local doctor, but I think it is really important to get that perspective. The second piece of advice that I would give is get connected. You know, the Carcinoid Cancer Foundation, NCAN, the NET Research Foundation, they are a treasure trove of resources. And Rain mentioned this at the beginning, but our patients are our biggest resources for one another. And chances are, if you have a question, that question is on someone else's mind or has already been asked.
Definitely.
And I don't think you can get better input from someone who's walked in your shoes and gone through your journey. And so I think that second piece is getting plugged in with our patient advocacy organizations, because that will help provide and navigate kind of what to look for in a doctor. What should I be asking? What else do I need to ask? You know, even if I'm satisfied with certain answers. So I think those would be the two biggest things that I would say are the initial aspects of starting one's odyssey.
Couldn't agree more. I chuckled a little bit when you were answering. I didn't mean to, but Dr. Ramirez wrote here, just as you mentioned his name. So yes, he is in attendance, as he usually is. Folks, one final announcement before we go. Yes, one of the other attendees had mentioned recovering from COVID. I am currently in the middle of it. My family is. We got kind of hit with it this week. As you can see, I'm doing well enough to conduct the show. We're not great, but a few of you have reached out and sent your well wishes, and I just wanted to thank you for that, and send some love to. I think it was Melissa who had mentioned she was just getting over it. But you know, take care of yourselves out there. Everybody, be safe. Everyone in our family except the baby got it, so he must. I think he has, you know, super genes or something like that. He's tough. But listen, Dr. Das, thank you so much for being here. We had outstanding numbers today, and I think that is definitely reflective of who you are in the NET community, and we appreciate you spending time with us.
Man, thank you so much. Feel better soon, and hope your family recovers well.
I appreciate it. And so, folks, I say that hopefully if I did my job well, you didn't notice too much, but sometimes I was muting my mic and kind of stepping off to the side. I'd still turn my head like it's contagious through the computer, but it's not. They told me it's not. But thank you all at home for joining us. As always, we hope this program helped answer some of your questions. And again, I reiterate, follow up with CCF if you have further questions, and know that this program you'll be able to replay it as soon as we're done. And starting Monday, it'll be on YouTube for those that don't have Facebook. We always want to thank our sponsor, Ipsen Biopharmaceuticals. Without their support, we couldn't do the show. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.